Welcome to this afternoon's seminar, and it is my pleasure to introduce our speaker, who is one of our own faculty members, Dr. Melissa Swan. She has been here for about 2 years, and as all of the faculty in this room are aware, she is up for her 2-year evaluation, and we have encouraged her to give this seminar so we can all get up to speed with what she's actually doing. So this is really the big purpose, and then just to learn something cool and something new. Just running over her CV, she first obtained an associate degree of applied science at Portland Community College. After that, you actually worked as a certified veterinary technician for a while before going back to school, first obtaining a Bachelor of Science in Biology from, was that from 2 different universities?
It's technically a Purdue degree.
Purdue degree, but it does say Indiana University as well.
Yeah,
okay.
It's a campus.
I see. Yeah. In 2018, you graduated with your Doctor of Veterinary Medicine degree, also from Purdue, and then a Master of Science degree, also from Purdue, in 2021. The topic of that work was proteomics of cancer cells, so also very interesting. And then since 2022, you've been here as a faculty member in the special title series, and as I said, up for her 2-year review. And with that, I'll hand it over to you.
Right. Can everybody hear me? Yeah. I have a loud voice, but always make sure. So I will stay in this corner. I am a traveler, so I'll do my best to stay in this corner. So when deciding what I really wanted to talk about for my 2-year review, I decided I was going to pick a rather obscure topic in equine bone marrow. And I selected this topic because this is maybe not something that was on my radar until I got here. And since I've been here, has become of great interest to me in my necropsy cases. But since this is my talk, I'll just click it. Yep, you're correct. Sorry about that. Okay, so since this is my 2-year review, I thought I would start by sort of defining what I've done since I've joined the diagnostic laboratory in this department. As Dr. Nielsen mentioned, I hold an appointment in the special title series where my appointment is 90.1% service and only 9.9% scholarly activity. So I joined the lab as an anatomic pathologist, a trained anatomic pathologist. And since joining the laboratory, there was a lot of expressed interest for me to advance my skills as a clinical pathologist and actually board certify in clinical pathology. So almost 30% of my total diagnostic caseload is actually clinical pathology cases. And those are broken up into anywhere from cytologic aspirates to bronchial alveolar lavage fluids that I read out of a lot of our equine patients, to abdominal and pleural fluids. Every once in a while, somebody sends me a urinalysis to look at, sedimentations for neoplasia and specifically urothelial carcinomas. And then though the CBC number, the complete blood count, blood smear number, looks really, really low, the vast majority of those are read out by my technicians, and I only consult on those. But I do a fair amount of blood smear work as a clinical pathologist. So in this sort of goal I've had in the last 2 years, I have spent significant amount of time training as a clinical pathologist with the Purdue clinical pathologists. And I just recently, 3 weeks ago, took the board exam, and I'm still waiting on the results. So I am very hopeful that within the next month I will have achieved dual certification. which will be a very big achievement, not only for the department, but for the diagnostic laboratory, because I will be the only clinical pathologist in this area in Lexington. So the other 60% of my caseload is as an anatomical pathologist, performing biopsies and necropsies. They are just as important, and I love them equally. But this talk is really focused probably more on the clinical pathology side of things, because I wanted to introduce the community to what I have to offer that may be a little bit different. So as of last November, the director approached me and asked me if I would take over as section head of the clinical pathology laboratory at the VDL. And as section head, I like to think that my job is not really to make huge changes, but is to guide and provide leadership to my 2 employees that operate that laboratory. And I had some goals for 2023 to sort of expand our operations and bring the clinical pathology laboratory up to a diagnostic standard that I felt was similar to other clinical pathology laboratories offered at other universities. So the first thing I went about doing is actually obtaining some new equipment. And one of the identified areas for me was actually acquiring a new CBC analyzer from the equipment that we already had. And the reason why I really wanted a new CBC analyzer is because the flow cytometry technology in CBC analyzers has advanced quite a bit in veterinary species. And there are machines now that are specifically made for veterinary species that provide me with graphs and cytograms where I can have great analysis as a clinical pathologist. And that wasn't currently provided with our current analyzer. The other thing I said about wanting to obtain was a cytology slide stainer that uses a Wright Giemsa stain. And while that may not seem like a huge get or a big piece of equipment, Wright Giemsa stain is actually really important for identifying mast cells in smear preparations, cytologic preparations, and bronchial alveolar lavage fluids. And at the time, our laboratory was having to do 2 prepared stains for all BAL fluids and equids because their mast cells are harder to identify on a standard diff quick preparation. So that has actually really streamlined a lot of our staining techniques and has eliminated some technician time on that end, and actually improved the turnaround time on my cytology readouts to generally same day rather than 1 to 2 days. So we've made some advancements there. In addition, we have brought on board a couple of new test offerings, triglycerides, which is not part of our standard chemistry panel here at the UK VDL. I needed that for chylus effusions, and then also new methylene blue stain, which does reticulocyte counts in every species but the equid, which doesn't have reticulocytes released in circulation, and then is really important in detecting Heinz body anemias. So moving forward, we have some 2024 goals for the clinical pathology laboratory, and those actually really center on our parasitology program, which, yeah. So our current parasitology program at the VDL is quite thin, and we're looking to bring on some new techniques, not necessarily new to the community, but new to the lab. And I'm hoping to utilize the parasitology group here in Nielsen's group in helping me to create the SOPs and the techniques. But that's next year's goal, and is an identified need for the laboratory. So we're looking at bringing on a quantitative fecal egg count, which I think will be a great service to our community. So as another component of service, the diagnostic lab has a partnership with Lincoln Memorial University, just like the Gluck does. And I do a fairly significant amount of teaching in the 4th year rotation. I teach 1 to 2 days a block, which a block is every 2 weeks, in addition to providing every block a 2-hour blood work analysis session for those students based on student feedback and need. And then the one of the other things I was tasked to do within the last 2 years was actually to restart the VDL's residency program. So many of our pathologists are trained, well, roughly half of them are trained by the UK VDL before the residency program shut down. And it shut down due to lean times, but it also shut down due to older pathologists that were of retirement age and maybe weren't as interested in training. And since our pathology group is fully staffed, we have expressed interest in really restarting this. The economic times are better. And as our partnership, with Lincoln Memorial has identified this as something that they really wanted us to do. So this is Madison Conway. She is our new resident. She just started in July, and I wanted to introduce the Gluck community to her. I hope you will give her a warm welcome. She comes to us from the University of Minnesota College of Veterinary Medicine, just graduated with her DVM degree in May, and will be with us for 3 years. We are also actively seeking another candidate for next year, and the goal for this program is really to have 1 resident per year. So it should be a 3 residency program. And I'm quite excited about that. And then this is a very wordy slide, and I do apologize, but scholarly activity is an important component of my appointment here. And I have made some effort to establish partnerships and relationships, not only with Gluck faculty members, but also with outside faculty members. I've served on 2 search committees. I've been to multiple meetings, and AABLD is one I attend every year. I've co-authored a couple of manuscripts, one by Dr. Page, who that just got accepted yesterday, so congratulations to him. And the other one I expect will hopefully be accepted too through Dr. Kane, a recent graduate here, and have also published a clinical commentary and a few lay articles. All right, so now I really want to get into the bone marrow, and I thought I would start by kind of giving an overview of how I actually approach bone marrow. Bone marrow, I've consulted on roughly 24 equine bone marrow specimens in the last 2 years, which maybe does not seem like a large number, but the average clinical pathologist will maybe get 1 to at maximum 2 equine bone marrow specimens a year in their career. So the number that I've been able to consult on in the last 2 years is pretty significantly more. And how I assess bone marrow, there's 2 major components to a bone marrow sample. The first one is the cytologic aspirate, which is the pictures at the top here. And then the other component is the bone marrow core. And they have really different functions and different benefits for a pathologist. The bone marrow aspirate is really, really useful in understanding cellular detail. So in bone marrow specimens, we're looking at those hematopoietic cells and looking for evidence of any dysplasia, disorderly maturation, even neoplastic changes within those cells. And the cytologic aspirate is really, really superior for doing that. The bone marrow core has the added benefit of giving us tissue architecture. And this is probably what I am more familiar with as a trained anatomic pathologist. But, and I will say that every case that I present to you today does not have a cytologic aspirate, because every bone marrow specimen I've seen since joining the laboratory has been a post-mortem sample. So that says a little bit as to how many bone marrow samples our clinicians are taking. It's not exactly a benign technique. In a live animal and a live horse, it's commonly obtained at the sternum, and there is a risk for puncturing through the sternum and hitting the pericardial sac and the heart. I've seen one case of that happen in my vet school program, and it was really unfortunate. So though it may not be a commonly sampled tissue, it is a tissue that I feel is highly important. And I think there's a lot of room for understanding how equine bone marrow actually differs from our other species. So the first thing I start with when I approach a bone marrow specimen is I look at the overall cellularity. And cellularity largely depends on whether the age of the animal. The younger the animal is, the more cellular I expect a marrow specimen to be. And in general, neonatal animals are reported to have greater than 75 to 80% cellularity of their bone marrow, whereas adult horses or senior horses have roughly 20% hematopoietic cellularity. So there's a really big drastic difference between old animals and young animals. And then there's this big gray area in between of our adult horses, somewhere between 2 and 20 years. The cellularity of bone marrow can range anywhere from 25 to 75%. So these are some examples here of different types of cellularity. Here's an incredibly hypocellular marrow where the only areas of hematopoietic cellularity are right here and some right here. This is a marrow that would be considered normocellular for an adult. And then this is a marrow that is hypercellular, where almost the entire marrow space is hematopoietic cells with only a very few adipocytes or fat cells present within the marrow. So after I assess cellularity, the next step is to really look at the individual cell lineages. And there are basically 3 major cell lineages to your hematopoietic cells. And then there are lymphoid cells, which we'll talk a little bit about as well. So the first lineage is the myeloid lineage. And I present this lineage first because it is the predominant lineage in equine bone marrow and really in every species, with generally at least 50% of the cell population in a normal equine bone marrow is this myeloid lineage. And up here at the top, I'm showing you different stages of maturation between these myeloid cells, with the bar indicating where we consider this the post-mitotic pool for cells, and this is the mitotic pool of cells. So it starts with the early myeloblast, the promyelocyte, the myelocyte, the metamyelocyte, the band, and then the segmented neutrophil here. And essentially every myeloid cell goes through a similar maturation phase. And so when I evaluate these marrow smears, I'm really looking at not only what sort of cells I have, but the proportion of cells I have to one another, whether or not I see all cell stages represented within the marrow, and then whether or not they're shifted towards one lineage or another. In general, there should be less than 1 to 4% of blast cells in a marrow for it to be considered normal. And there should be 4 times this number of cells in the post-mitotic pool than there are in this mitotic pool. So it should be heavily skewed towards these cells here in the myeloid lineage. So what I've shown you here are, I'm just giving you some different examples of cells, myeloid cells, and how they appear in the marrow under different conditions. So this figure B here are myeloid cells that have complete and orderly maturation. We see some of those blast cells, but we see a greater proportion of band cells here, and a few segs. In C, here is a situation where we have disrupted maturation, where we have more of these mitotic pool cells than we have cells in the post-mitotic pool. D is a figure where the myeloid cells actually are toxic. So there is a bone marrow injury here, and there's toxicity in this line that is causing these cells to be bluer than they should be, and they also have these vacuolations and irregular granularity that are quite abnormal. And then the last situation is a neoplastic situation where we have a proliferation of all of these blast cells that are of the myeloid lineage that have these fine granules in there, and that's consistent with an acute myeloid leukemia. Why is that dark? Well, I apologize for how dark that looks. So the same sort of thing I do for each lineage. I do it also for the erythroid lineage, where we have, again, the mitotic pool, and then we have what's considered more of the post-mitotic pool down here. And I look at all of these different stages. In general, the erythroid lineage tends to be a cell that has a more basophilic cytoplasm with these prominent perinuclear clearings and no granularity that I can see. And as the cells progress towards maturation with multiple divisions, at some point in almost every species besides avian and reptilian, they will kick out the nucleus and give it an exodus and say, goodbye, I don't need you anymore, and become fully hemoglobinized, which is what we see in peripheral circulation. Oh, I apologize. I was animated.
Are all these slides we're looking at equine?
No. So most of these slides are dog bone marrow pictures. There is not great published data on equine samples, and these are cytologic aspirates, which are much better at evaluating morphology. I'm going to present to you some equine cases in a minute, but this is just, I wanted to hopefully give you a better idea of what I look at. So then the last lineage is the megakaryocytic lineage, and the megakaryocytic lineage represents less than 1% of the total cellularity within a normal bone marrow sample. And there's really only 3 cell stages to the megakaryocytes, so I kind of really like them because they are rather easy to assess. And so you have your megakaryoblast, your promegakaryocyte, and then your megakaryocyte, which is mature. Your megakaryocyte is a multinucleated cell, but instead of having distinct nuclei, all the nuclei are fused essentially and incompletely fissured, which is sort of their normal morphology. In general, the number of megakaryocytes should be assessed based on the high power field that you're looking at, but in a cytologic aspirate, in general, it's generally 1 per 400x high power field or 2 to 5 in a histologic sample. Okay, so now I'm going to get to the equine cases and hopefully show you some work that I've been doing with these bone marrows. So the first case is a 13-year-old thoroughbred gelding, and this gelding came to me on first as just a blood smear. I was just provided very little information in a peripheral blood smear and asked to evaluate it, with the history that the horse was persistently pancytopenic for more than a week after repeated sampling, and I was only provided with really this brief data of a white blood cell count that's 2.54, which is really low, so severely leukopenic, a very severe anemia, and then a really severe thrombocytopenia. And this is a representative field of what a monolayer of a blood smear looked like in this horse, where there's essentially no platelets that I can see. There's no white blood cells within this field, and the number of erythrocytes, which in a monolayer should be 50% of them should be overlapping, are so sparsely spread out here that you would think that I was in not the right spot. The other thing that's interesting in this blood smear is that there's quite a bit of what we call anisocytosis, or variation in cell size. So this red blood cell compared to that red blood cell are quite different. And anisocytosis on a blood smear preparation actually in horses can be an insensitive but a useful indicator of regeneration. Since horses don't really show polychromasia in their blood smears, and they don't show reticulocytes, which are 2 useful tools of regeneration, anisocytosis is one of the things that I actually utilize to assess whether or not I think there's any evidence of regeneration. So this horse, unfortunately, the prognosis for pancytopenia is pretty poor. And when the clinician called me, I told them that really the next step is to do a bone marrow aspirate, that I thought that the pancytopenia that they were reporting is truly persistent and very real and not an artifact of sampling. And that likely this was not going to improve. But without a bone marrow aspirate, I really can't tell them much more than that. So I was very interested, so they sent this horse for necropsy. And what you're looking at are cross sections of multiple different femurs. So I split both the femurs, the long bones, and I'm looking at the marrow space, the diaphysis, which should be full of fat in this age of animal. And then up near the metaphysis, the marrow should have some degree of pallor. But what is really interesting about this marrow is these red sort of banded lines that are actually correlate with higher concentrations of hematopoietic cells. But you can imagine that if the marrow is this inconsistently colonized, that when you take a marrow aspirate, you might not even hit where the cellularity is where it is. So this is what this gelding's bone marrow looked like on H&E. And what I try and do is I assess the relative number of adipocytes or fat cells to the overall hematopoietic cellularity. And in this bone marrow specimen, I estimated the hematopoietic cellularity to be less than 10% of the total cellularity within the marrow. And so on further magnification, there are these, and I did animate, there are these aggregates of macrophages within this marrow that actually contain relatively large amounts of iron, which is this yellow-brown pigment, as well as intact or partially lysed erythrocytes inside those cells. So anytime I start to see pretty prominent erythrophagia, that's actually quite concerning in a marrow. And horse bone marrow is actually supposed to have iron stores in this, but these iron stores are really quite prominent, which I highlighted here with a Prussian, or sorry, not a Prussian, a Pearl's iron. Prussian blue is also an iron stain, but and so all of this blue material that's in these macrophages is actually iron, and quite a lot of it. Looking at it further, what I also noticed is that there's this sort of clustering of what appear to be lymphoid cells within this marrow, and that the overall number of myeloid cells, though they're here, are quite sparse. So all of that is really quite atypical and really fits with the pancytopenia that they were observing. So the liver in this horse was really quite interesting. And what I observed basically throughout the entire liver was massive amounts of this brown, golden brown pigment, not only within the Kupffer cells, but it's also within the hepatocytes. So there's this brown pigment. And then I further highlighted this with the Pearl's iron stain, which stains iron, and it lit up like a Christmas tree. I've never seen a liver have this much iron in my life, except for this case. So this prompted me to get Dr. Romano involved, because liver iron stores should never be this high. And Dr. Romano went ahead and ran a mineral analysis on this horse's liver, and it came back at 4,490 parts per million, which is well above the reference interval expected for horses and is consistent with a diagnosis of hemochromatosis. So this is a case of hemochromatosis induced aplastic anemia, which is reported in humans and very rarely reported in humans and has never been reported in horses. So I was quite excited to make this diagnosis. There are two recognized forms of hemochromatosis: primary, which is a hereditary form, And in humans, they've demonstrated mutations in these different genes, the HFE, hemojuvelin, hepcidin, and the transferrin receptor 2, which are all important genes in encoding iron metabolism. But this has never been demonstrated as a hereditary defect in horses. And so this case is more likely, given the age, as a case of secondary hemochromatosis, which can be iatrogenically induced through the administration of injectable iron supplements or through high iron water sources. And very rarely, they do describe it with blood transfusions and multiple blood transfusions. So there's this really nice paper that sort of characterizes chronic iron overload in this case study of 21 horses and 1 donkey from they were from the same site in this paper, but they were all not genetically related. And they necropsied 12 of these horses, and 12 of these horses had the same exact lesions. So they felt pretty confident in calling it hemochromatosis induced hepatic cirrhosis. But what was interesting about this case report is that they report cirrhotic livers and not necessarily just iron overloaded livers and aplastic anemia. No horse in this study had a pancytopenia, and no horse, and only 5 horses within this case report had described anemia. So this is really quite interesting to me that this horse presented in a somewhat different fashion. So the next case I wanted to talk to you about and present is a 13-year-old thoroughbred gelding. This gelding also presented to the necropsy floor, but prior to presentation to the necropsy floor, I was sent a blood smear preparation from a local clinician from a prominent equine hospital to review the cells within this preparation, and was provided this data on a CBC data from the time that the smear was made. This horse was identified as having a pretty profound leukocytosis for an equine, with a mature, a left shifted band neutrophilia, and then the lymphocyte numbers were pretty pronounced in here, so lymphocytosis. And on the blood smear preparation, all of these cells that I'm showing you here are lymphocytes. And in general, blood smears in horses, lymphocytes tend to vary in size, but these lymphocytes are quite large in appearance. They are greater than 2 of the red blood cells, and they have really atypical chromatin patterning and this irregular nuclear folding that made me highly concerned about either leukemic phase of lymphoma or leukemia and a bone marrow infiltrative disease. So they opted, because this horse did not improve despite their medical therapy, to actually send the horse to the necropsy floor, where I received it again. And this horse had some really interesting dermal lesions seen here, where there's at the coronary band, perinasally, and even around the eye, there's this sort of crusting-like lesion that is not dirt and debris and consistent with an exfoliative dermatitis. And this exfoliative dermatitis on histology coincided with a condition that we call idiopathic granulomatous disease. It has also been termed sarcoidosis, but the pathologists really don't like that term because they tend to get confused with sarcoids, which are an entirely different process than what this is. And this is characterized by this dermatitis that has large numbers of macrophages and these multinucleated giant cells. This case in particular, the dermatitis was really centered at the interface, and there are a lot of these large atypical lymphocytes present there as well. On necropsy, the horse's lymph nodes were markedly enlarged. Submandibular shown here, and then the inguinal shown there. And that coincided with this tan to white bulging lymph node which was consistent with lymphoma, which I'll show you further. What was sort of interesting about this horse was its heart. The heart valves were dramatically thickened in this case, and almost 5 millimeters thick. And lymphoma is not generally associated with valvular infiltrates. So this was a really weird pattern for me to see as a pathologist, and to see lymphoma involving the heart valves. And these lymphocytes that were present were highly atypical, very, very large in size, and had a lot of the irregular nuclear folding and chromatin patterning that I was seeing on the peripheral blood smear. I went ahead and performed some IHC on these neoplastic lymphocytes, and they stayed strongly positive for CD3, which is an antigen associated with T cells, and they were negative for CD20, which is an antigen associated with B cells. So I ended up diagnosing a highly anaplastic T cell lymphoma, and actually a T cell leukemic lymphoma. So, but I'm not done because the bone marrow is coming up. So this is this horse's femur on cross section. And again, what I'm noticing with some of these adult bone marrow diseases is that the concentration of hematopoietic cells is really irregular within these marrows. So I find that pattern really, really interesting and very inconsistent. But in general, this is a 13-year-old horse. The marrow is supposed to be paler than this red pallor that I'm seeing here. So that's the sample I wanted to take, was where that pallor was really great. And this is what this marrow looks like on subgross evaluation. It's highly, highly cellular. I estimated this cellularity to be about 85% cell, hematopoietic cells, and only 15% adipocytes. And if we kind of go back to what I was talking about, in generally 25 to 75% cellularity is considered normal in an adult horse. So this is too cellular. And there's these tinctorial staining differences where you get these aggregates of cells that are sort of paler staining that I'm highlighting here, which are Bruno's favorite cell. And there's these irregular clusters of large macrophages / monocytes in this marrow, which I thought was really fascinating because Dr. Cassone had another case of this idiopathic granulomatous disease where I saw the exact same sort of clustering of these macrophages and monocytes. So they're definitely being overproduced in this marrow. In addition, there is this very sort of subtle, but there's this clustering of large T lymphocytes within this bone marrow that, again, when I put my immunohistochemistry stains on it, highlighted T cell origin, that I do believe that there was some marrow infiltration of this lymphoma present. So I ended up reading out this case with a final diagnosis of anaplastic large T cell leukemic lymphoma. This only represents less than 1.5% of all equine lymphomas. So it's a very rare lymphoma in the horse. With bone marrow hypercellularity, myeloid hyperplasia with the expansion of this monocytic lineage that I believe was likely due to the skin lesions. And I think the skin lesions in this case were probably paraneoplastic, but idiopathic granulomatous disease in horses is really not well understood at all. So we have some work to do on that. And then the megakaryocytic lineage in this marrow aspirate was also hyperplastic. There was a lot of megakaryocytes, more than what I would expect. All right. So the last case I wanted to go in, and perhaps the most perplexing case to me, is a case of neonatal maladjustment syndrome. So this is a 2-day-old thoroughbred filly foal. The history provided to me was it was born via C-section to a mare with GI perforation. So they had to euthanize the mare. Severe neonatal maladjustment syndrome was clinically diagnosed. The foal had developed seizures, hypothermia, and hyperglycemia with evidence of multi-system organ failure. They euthanized this foal on the 17th, but they provided me with 3 days of CBC data, which I always appreciate as a clinical pathologist. And this foal trended towards leukopenia and trended towards anemia, but the platelet lineage was still within reference interval. So this prompted bone marrow sampling, which is the whole theme of this here. And this is what I saw. So neonatal bone marrows, which I will highlight that there is like one neonatal equine bone marrow paper. So nobody knows a lot. But neonatal bone marrows in pretty much any species are described to be greater than 75% cellularity. This bone marrow is hammered. Essentially, all what we're really seeing here is congestion from the bone marrow sinusoids and erythrocytes that are in circulation with adipocytes and very, very little cellularity. And I do apologize because this sample is a bit over decalcified, so the tinctorial staining isn't right, but the cellularity is just profoundly, profoundly hypocellular. When I could find hematopoietic cells to evaluate, I was quite interested to see that though megakaryocytes were here, they were absolutely reduced in number, and this is the only megakaryocyte in this section. And in general, the only cell lineage really well represented here are the myeloid lineage, which I'm pointing out here. But this myeloid lineage is severely left shifted. And left shifted means it's shifted towards the immature stages of that marrow, indicating that there's a lot of tissue demand for those cells. In addition, there's all of these smaller cells within this marrow, which coincides with lymphocytes. And the lymphocytes actually look increased in this marrow, but they are not truly increased. They appear increased because all of the other cell lineages are largely absent. So what I ended up calling this was severe hypocellularity with left shifted myeloid hypoplasia, megakaryocytic hypoplasia, and erythroid hypoplasia, because I had a really hard time finding them, with absent hemosiderin. I almost probably could have gone bone marrow aplasia, and aplasia is really defined as less than 5% of any one cell lineage is enough to call aplasia, but clinicians get scared about the aplastic term. That's not a fun term to throw around. So this prompted me to have a lot of questions, and this is really, I'm really excited about this, because over the last year, probably I've done 8 to 10 different neonatal maladjustment foals that have massively hypocellular marrows. They are just profoundly different than what I have been trained to recognize as normal, and I don't know why. So the question really is this part of this syndrome, and is the prevalence of bone marrow hypocellularity a huge component to why these animals do so poorly? And is there a way that we actually could recognize that sooner, so that our producers are actually not inputting money into something that is actually never going to recover because it doesn't have appropriate hematopoietic cellularity? Or is this something that is being induced in the course of treatment? And I don't think it's really the latter thing. I don't think it's a treatment related effect. I think it has to do with really poor colonization of the marrow in the 3rd trimester, when your hematopoiesis shifts from your liver and spleen and actually colonizes the bone marrow, and the bone marrow sort of takes over. And that anemia that I'm seeing in these cases is really, really important to me, because neonatal erythrocytes, they have a long half-life, but it's less than the 140 days that adult equid erythrocytes are. So to see profound changes in those when they're born indicates that the event that caused the aplasia or the severe hypoplasia had to be in utero. So my goal really is actually to do more sampling in the next year of these neonatal maladjustment syndrome foals and to further characterize this so that I even can have a reference point to start to help to advise clinicians on what's happening within this syndrome. In addition, all of the literature and texts talk about iron storage in horses and the fact that hemosiderin stores are readily visible in bone marrow of all equids, but nobody understands when that happens. And most of these neonatal maladjustment cases, I can't find any iron in storage, and we've run a few of them on mineral analysis, and their body iron stores are fine. So what that says to me is it's not necessarily they're iron deficient. I don't think they're. Right. Okay. It's not, they're not iron deficient is my point. They're not iron deficient. They have adequate iron. It's just they haven't colonized their marrow with hemosiderin stores that are visible yet. So
these young folks that are at this poor developed bone marrow, how's their liver?
How's their liver? So the question is what about these neonates that their livers? There is not extramedullary hematopoiesis in significant amounts to account for why their bone marrow is so poorly colonized. And in general, most clinical pathologists I talk to about extramedullary hematopoiesis have questions about whether or not it's truly effective. However, I have the caveat of this, I'm not 100% sure that's really correct because extramedullary hematopoiesis is where it starts, and then it transitions to the marrow in the third trimester. So, and those organs very specifically have fenestrated sinusoids to allow cells to pass in and out. So in these cases, it's a great question. I was not noticing colonization there to explain or potentially help what's going on in the marrow here. Did I answer your question, Bruno?
Yeah, I'm just curious because of some other species, the liver still might be
Active.
one active source of hematopoiesis.
Correct.
And whether those patients were having a delay.
Right. And in these ones, I'm not seeing colonization there. In other young neonates, I have seen extramedullary hematopoiesis, and I see it more in the spleen than I do the liver, but I've seen it in the liver as well. So, and then sort of the last thing I really want to do is I don't have a good post-mortem method for cytologic aspirates. This was not something I was trained to do. That I'm really interested in actually working on a technique. So I would love some help with anybody who has familiarity with doing bone marrow cytologic aspirates to potentially maybe come help me learn the technique and then also perfect the reagents and the media that is needed to increase the viability so that I can look at these cytologies. Because the next question I really have is there significant dysplasia in these cell lineages as well as just hypoplasia to aplasia? And I can't answer that very well with cores. That is really a question that's better answered via cytology. So with that, I have a lot of people to thank, but I work very closely with all the UK VDL pathologists. They have really, really helped me to advance as a pathologist in my career, and we're willing to take a chance on someone who's just out of training and really have just championed me. Dr. Romano has been extremely helpful with all my tox cases and answers all of my weird questions. And I have a lot of support in our technicians. And then these people at Purdue, particularly Dr. Messick, is an incredible bone marrow expert. And I tend to run all my cases by her and ask her questions, but her repeated answers to me are, I've seen maybe one neonate, I've seen maybe one of this. And so it just really shows that I think there's a lot of work to be done here. And that this is really a potential area where I could add some value to the community.